All right. Thank you for the introduction, and thank you for being here, spending the next hour with us, choosing our session. I hope you find it informative. Before we start, I thought of asking maybe a couple of questions, a little survey. We are curious to know who in the audience already has an RTLS system implemented at the facility this time. 1, 2, 3, 4, 5. Good. Who is actively evaluating different vendors with budget already secured, to implement such a solution? Anybody? No? And my last question is there anyone that is in a facility that decided to discontinue so decided either, oh, that happened, and there as well. So that's interesting, and so maybe in the Q&A we can talk about that and different experiences. Feel free to ask questions as we go along the presentation. We'd like to make this as interactive as possible. All right, so my name is Michele Manzoli. Yes, it's spelled like Michele. Welcome to my life. I currently manage the clinical engineering team at Cedars-Sinai in Los Angeles. I'm also on the board of the American College of Clinical Engineering. If you haven't already, please feel free to stop by our table by the entrance to the expo hall and inquire about membership, our educational offerings, as well as a certification program. If my name didn't give it away, I'm Italian. I was born and raised in northern Italy. I went to school there, and I started my career in the medical device regulatory affairs field. An interesting field, but after a while it got a little bit boring. So looking for new challenges and adventures, I flew across the Atlantic Ocean, landed in Boston 9 years ago, and I've been part of the American HTM community ever since. I started at Cedars-Sinai 7 years ago as a clinical systems engineer in the clinical engineering and device integration team, and it was in that capacity that in 2021 I led the pilot for RTLS and subsequently the housewide rollout. When I moved on to my current role, I passed the RTLS baton to Jazz. Jazz?
Morning, everyone. Jaspinder here. As Kelly mentioned, I go by Jazz for short. I am currently a clinical engineer here at Cedars-Sinai. I have past experience from working in the Northwell Health System in New York. I've been at Cedars for roughly a year and a half now. Based off of education, I did get my bachelor's and master's in biomedical engineering, also at SUNY Binghamton in New York.
All right, our agenda today, session summary, a couple words about our organization and our team. The meat of the presentation will be our RTLS journey, lessons learned, what we've achieved, some return on investment considerations, and then finally, what we are planning for the near future. Not too much, I'm not going to spend too much time here because I believe most likely the reason why you're here is because you read this summary maybe on the website or a magazine and thought that might be interesting to hear about. If not, this is the summary, and so we're going to talk about our deployment of more than 14,000 tasks in our institution. Probably you've heard of Cedars-Sinai. We are a nonprofit hospital serving the Los Angeles area. Licensed for almost 900 beds. We've been recognized 8 years in a row now on the best hospitals honor roll, quality patient care, medical research, academic education. The figures here give you an idea of the size and the activity how busy we are every day in our hospital. As for our team, we manage over 30,000 pieces of equipment. We have 24 techs, 4 engineers, and we report to IT. So the 3 most common reasons to implement RTLS usually are: number 1, reduce time searching for equipment, and this translates into more time spent with patients, or in general more time spent doing value-added tasks, equipment management, performance improvement, because the time spent searching for equipment is wasted, clearly. Number 2, reduce staff frustration and improve morale. That's important. And number 3, improve workflows and productivity. And you do that analyzing for example, the locations history that your RTLS system collects. So going back, you're able to determine turnaround time metrics, things like delivery time, cleaning time, idle time, understand how long assets have been in certain locations, and so that helps you understand a little bit more about the utilization of the assets, especially shared equipment. See if it's being utilized to the fullest. Understand if a certain nursing floor really needs 5 bladder scanners, or they could do with 1 or 2, and things like that. Of course, number 3 requires some skills and some time and effort spent diving into the data, asking the right questions, the right query, and be able to understand and interpret the results. But it's a pretty powerful data that the team can then use to justify changes, improvements, or optimization. Whereas number 1 is straightforward. That is the first benefit that an organization can achieve. For number 3, you need to do a little bit more work. There are so many different flavors of RTLS nowadays, from infrared, different technologies, from infrared to ultrasound, from ultra wideband to BLE, you name it. At Cedars-Sinai, we already had some infrastructure in our hospital because, and this is quite peculiar, I believe, from what I understand, usually facility maybe start tracking assets, and then after a while they move on and decide to expand the implementation to maybe staff members or even patients, right, with special badges or wristbands, and they would leverage the same infrastructure. Well, at Cedars-Sinai it was a little bit different, because about 10 years ago, a little over 10 years ago, when we replaced entirely our nurse call system, we upgraded with a different vendor. It was decided, by our leadership to also include some kind of RTLS infrastructure to support the nurse call automation, the cancellation of nurse calls for our nurses and clinical partners, so that they could cancel patient calls just by entering the patient rooms. So it was a decision that was made strictly for that reason, and it's been like that for many years afterwards. In fact, the asset tracking wasn't implemented until 2021, as I was mentioning. During the pandemic, lots going on, clearly. Everybody's very busy. And nursing, who had been asking for this RTLS, so this actually came from the nursing side, finally was able to convince administration to invest and implement such a solution. And so our infrastructure consists in infrared emitters, in low frequency exciters, and the ultra high frequency access point. again, we didn't have to install much more of what was already installed in inpatient spaces because of the nurse call implementation. We did add some infrastructure in specific clean utility rooms, soil utility rooms, storage rooms for our purposes, for car level management. But we decided not to install these proprietary infrastructure in outpatient spaces like ORs or procedure spaces for a number of reasons. So how does our system work? It all starts with these infrared emitters. They work like lighthouses and emit this infrared signal that contains a very specific location identifier. So for example, if we install this device in room 101, this battery-powered device will start illuminating the room with infrared light with a certain ID. The tag that we apply, on the medical device has an infrared sensor that detects the signal and is able to communicate this information along with its own tag identifier via ultra-high frequency to a proprietary access point powered over the Ethernet, so connected to the hospital network all over the organization. The information of the tag along with the location travels to the hospital network, reaches our virtual servers where processing happens, and that allows then the users who accesses our RTLS application to see the device both on a map or on a list with the location identified. There is also a secondary pathway that we represented here, the Wi-Fi option, because we wanted to have visibility also in those places where we couldn't install this nice battery-powered infrastructure. In fact, the tags that we use also support Wi-Fi, so they send Wi-Fi probe packets every 5 minutes that are received by our hospital access points. And so we are leveraging our Wi-Fi network location services platform, which can be considered as a separate RTLS, that through triangulation is able to calculate an approximate location of the tags, similarly to what it does with other network devices like laptop, iPhones, or tablets in the hospital. So this secondary pathway is both a second way of locating things, but it's also a bed for our primary. And I'm going to expand more in a couple of slides. So you understand, depending on the pathway, we have two types of maps. One is more accurate; it's a room-by-room location. We provided the architectural drawings to our RTLS vendor. They built this nice map using Visio, and the room level accuracy is possible through thanks to the emitters that were installed in every single room. This battery-powered emitter, so that requires constant maintenance. So you see, our patient rooms, our hallways, the nurse station, med rooms, toilet rooms, clean utility rooms, storage rooms. Each one of these rooms has a device. The second type of map is, we call it, Wi-Fi map, and it has an area or zone level accuracy, because we know that through Wi-Fi you're not able to pinpoint a specific location, and of course it depends also on the number and layout of your access points in your facility. It may also cause hopping between floors if you don't have enough access points or if they're not properly located in the facility. But we thought that in areas like ORs, our GI lab, cath lab, or other procedure spaces, that was already better than nothing, right? So we drew zones in our architectural drawings, and the system that communicates with our Wi-Fi location services platform is able to show our devices that are located through Wi-Fi. The North Tower and the South Tower in our facility are inpatient spaces, so we do have infrared emitters in these locations, but we decided to include them also in the Wi-Fi maps because of the limitations of infrared technology. So if you put your small device into a cabinet, you cover it with a thick material, the tag will not see the infrared signal. And so we wanted to have the ability to still see that a certain MIDI device was hidden inside the cabinet. And so we would see through Wi-Fi, not through infrared. We wouldn't have the exact location, but at least we knew that it was around a certain. So that's why we decided to replicate the locations that we already had, in these very detailed maps, in the Wi-Fi maps, exactly for this reason. 2021, the middle of the pandemic, nursing said, we really need to, we cannot waste more time. We're so busy, we need to do something. And so, again, finally, budget was allocated, and they gave us the green light to start with a pilot proof of concept. So it took us about a month to prepare for the pilot. So from mid-March to the end of April, we had to install some devices, we had to configure them, we had to tag a number of pieces of equipment, create the maps, train the end users, as well as validate the application. And then we went live on 2 nursing floors, as well as the lower level of our facility, which is where clinical engineering and central supplies are located. We tagged about 700 devices. These are the categories of devices. They were recommended by our clinicians. So I believe that this could be a good candidate in case even in other organizations, because they were described as the piece of equipment they were being challenged in terms of finding, from wheelchairs to bladder scanners to the vein finders, to tally boxes, and things like that. Even the PCA pump or PCEA pump keys, which we found it interesting, but it helped them a lot to have them tagged. So 700 tags, we clearly didn't have all our infusion pumps. We had more than 5,000 in our facility. We tagged a sample of that because we wanted to see how the tag would resist the whole cleaning process, because they're centrally distributed, so they're transported all over the organization, cycled through our central supply, and so we had some lessons learned. So we have the sample of infusion pumps, a sample of our SCDs, and then the other devices were only limited to these 2 nursing locations, nursing floors. So what did we learn from the pilot? Hardware firmware compatibility updates. We did have some issues where, for the different components, you need to make sure that they're all on the same firmware level to ensure there are no communication hiccups. As you can imagine, we did experience, detached tags, and that depends on a variety of reasons. Depends on how equipment is cleaned, depends how the tag is, positioned, is attached, and a variety of reasons. So we learned about the importance of spending time to really find the optimal location for the tag on on a specific device. And there are bigger devices, smaller devices. Actually, something that I did not mention before is that we actually use two types of asset tags. We use mostly the one that is Wi-Fi capable because of what we talked about. But certain devices like our glucometers or vein finders or teleboxers are so small that our standard tag just wouldn't, there wouldn't be enough space. So we had to opt to use the smaller tag. Of course, the limitations of this tag is that the battery doesn't last as long and it doesn't have Wi-Fi. So there was, a limitation we were aware of, but again, it was better than nothing, right? So detached tags, we went back to the drawing board and decided to tag things differently, make it maybe using zip ties and finding creative ways to make to make sure that these tags would stay attached for as long as possible. I mentioned that we are using the frequency exciters. There are a couple of use cases, and Jazz will expand more on that. So we that installation we had to go back and forth a few times because they're very sensitive and we were experiencing many false positives. So whenever that would enter this the field of low frequency, it will cause a notification to go to our nurses' phones. And so just we learned that we had to spend more time to properly locate these devices on the walls and properly test and validate that they wouldn't cause any false positives. We experienced a number of out-of-the-box failures with the tags. Unfortunately, we didn't expect that. And unfortunately, we found out when it was too late, when we were, when the assets were already deployed and who knows where they went. So that was about 1% or a little less of our first phase of deployment, and that made us rethink and do things differently for our second and third phase. So now the way we are the way we implemented, future, subsequent tagging is a little bit different, so that we first verify that the tag works, communicates with our application, and then we tag the device. Initially, we took for granted that it would work, but then we found a number of defective tags. So lessons learned, and then need for spare parts. So in addition to the tags, because of our specific item, we needed to buy a large stock of cradles, adhesives, so that we can properly manage the devices. Pilot was successful. We got good feedback from nursing. They really liked it. They wanted to expand it, and so we thought, all right, we have the budget to expand it, but we want to do things the right way. So we took the time to do some research. We read articles, we listened to webinars, resources like AMI, ECRI, even the TechNation magazine. There's some articles about RTLS. Every once in a while, we ask questions and asking colleagues from other institutions. And so we listed our keys to success. So we wanted to be properly positioned for a successful rollout. And so we thought, first, we need a multidisciplinary committee. We need to form a committee for governance because once this thing goes live, there needs to be a proper governing body. Number two, we're going to need a lot of resources for supporting and making sure that this program stays alive and healthy. So battery battery management, that means battery monitoring and replacement, both as needed or proactively, but also support on the application side and backend, who manages the server, who manages the application, and the workflows around RTLS. Then we needed to develop appropriate training for both our clinical end users, but also for our clinical engineering technicians who work more closely with the application and with the replacement, the battery replacement workflow, and just making sure that our inventory on the RTLS side is as accurate as possible. We had to work with nursing leadership to make sure that RTLS, at least a one-page quick guide, was included in onboarding to make sure that the new staff be at least aware of it and would use it as needed. We wanted to be as inclusive as possible, so we involved all hospital stakeholders, even teams that you would normally not think they would benefit from RTLS, things like pharmacy or lab, and we will talk about those because we just wanted to make the best use out of it and create as much value as possible once we made the investment. And then we knew we needed to establish clear criteria for inclusion in the program because we knew folks would gonna ask us to tag everything and anything, the most incredible things. So again, along with the multidisciplinary committee, we agreed on specific criteria that would determine inclusion or not. And finally, we worked with our help desk to write workflow to provide directions to how to redirect support questions so that the team could, the appropriate team could address it. We also want to recognize our RTLS vendor consultants we worked with who provided some additional useful recommendations from organizing an awareness campaign, so through the use of signs and screen savers. We did see an increase in the use after we did this awareness campaign. They suggested creating a standardized naming, asset naming schema to keep things uniform, make sure that we call devices the same way no matter where they are, and just make it simple for end users to find on the application what they're looking for. They recommended establishing a formal tagging request intake process. They also recommended to appoint a nursing division champion as well as nursing unit representatives. So for each nursing course, there is now like a unit representative that helps with creating some accountability, because of course the project team couldn't take on the whole, all the weight, and so through the nursing unit representative and division champions, we had a network of ambassadors to help us, again, create awareness and train and make sure that the staff was aware and they were using the system when needed. They also made us aware of the possibility of setting up rules, notifications to be sent out whenever certain assets maybe were leaving a floor they weren't supposed to leave, or for assets that stayed in a certain location for way too long. So maybe that's a sign that they would not be properly utilized. There are also notifications that can be set up for equipment susceptible of theft or unintentional loss. think of the tally box that ends up with linen or or other small devices that are unintentionally lost. High-level monitoring in clean utility rooms was another very interesting idea to explore for us. And then they recommended tagging structures and beds. They're not under the clinical engineering purview in our institution, but I can confirm that our plant ops team is now very happy that the beds are tagged and they're able to find them when it's time for PM. So they're really appreciative, and we actually partnered with them. Finally, integrating with CMMS. We haven't done it yet. We are looking forward because it would make our life so much easier to show on the one side the location of a certain asset directly on our CMS interface, and on the other side we wouldn't have to enter all the device attributes twice in the two systems, because the RTLS would ingest directly the device attributes from the CMS. All right.
Thank you, Michele. So to really jumpstart the RTLS program, as well as encouraging end users to use the program, at Cedars, we did develop an RTLS workflow committee. This committee consisted of representatives from multiple departments. And these meetings were, initially, we didn't meet quarterly. We didn't meet monthly, but we did shift to quarterly meetings. And here is a workflow committee charter, just to show the breakdown of just what type of individuals were attending these meetings. We had everyone as high as the executive sponsors, such as the nursing directors, followed by some committee leads, such as the clinical engineering manager, nursing managers, and then a lot of key members throughout the facility. So just the scope of these meetings, we typically would start these meetings with having users letting us know what issues they're having with either finding equipment or losing equipment. And we would often follow up with solutions that we can implement with RTLS to solve these issues, as well as also providing education on where currently we are, where we stand in the RTLS implementation progress. And then finally, really letting the end users, as well as all the internal stakeholders, really know where we're trying to get to with RTLS, and really ending off these meetings with success stories, as it did provide more morale and usage of the system. So as Michele mentioned, post-pilot, we did realize the need to budget for ongoing support. We did feel that we would need about 1 to 2 full-time employees for on-site support. This would be for battery management, such as replacing batteries. We also did see, as mentioned before, roughly about 1% of batteries that were getting detached, primarily essential issues. However, you do know that within the nature of the hospital, there is a lot of equipment that is leaving or retiring, or we are always adding equipment into the database. So tag management was also another reason. Also needing 1 full-time employee for the system application support, such as server ownership, backend support, requesting for expansion, and alerts and report creations. So end user training is also available at Cedars education portal. It's a little screenshot. Beauty behind this is that it allows the end users to pause, play, rewind, and watch this video at any point in time, and they can keep rewatching it for more clarity. However, clinical engineering is also very available. If there are any other questions, concerns outside of the education, we are more than willing to help out. So criteria for tagging, as mentioned, to justify the cost of the tag as well as the long-term maintenance, we did set specific criteria on what can be tagged. As Kelly mentioned, we can't tag everything. So the equipment does need to be valued at roughly $500. We also want the assets to also satisfy at least one of the following criteria. We want the asset to also improve clinical workflows, to prevent accidental loss, to facilitate maintenance workflows, For example, for clinical engineering, tagging equipment does help with preventive maintenance on our equipment, so faster we get to our equipment, less chance of missing the PM. And then, as mentioned, for other departments, such as point of care lab, bed shop team that also service their own devices, it allows them to really pinpoint these devices and get to them as soon as possible. Facilitating transport workflows also, as well as increasing operational efficiency. So the device should also have a flat surface for tagging. Say this because these tags do come with a flat 3M adhesive end. So typically it is not ideal to tag on regular surfaces. However, we did, for in special cases, we have used zip ties to combat this. However, that is one of the limitations if the device does need to have a flat end. Any other requests, any special requests that are to be made outside of what is listed here, we typically do on any special instance basis. They do need to be approved by clinical engineering leadership. So naming conventions are also very key to maintaining and standardizing our RTLS database. As Michele had mentioned earlier, our consultants also did recommend that we keep this uniform throughout. And the way we went about at Cedars is we typically tend to put the floor or the department that the device is going to be affiliated with, followed by the name of the device, and then typically a sequential number, which is a unit identifier. Here we have an example. 8S is for 8 South. It is a glucometer, and number 3. So we will have equipment just listed all in the same manner, and it does provide ease for the end user. And then shifting into asset groups, this is also another indicator. Asset grouping, the creation of groups does provide more filtering for us, and also does aid in the ease of use of the database. So just using the same example from prior, we do have a group called 8 South glucometers. So 8 South can filter out the database and just glucometer to see exactly what they have and where. So tagging requests, when end users do want to place requests to tag, we do have a ServiceNow portal. We have an electronic form which they can fill out. In this form, typically we want them to identify the name of the device, the quantity of the device, and just let us know where this device is being placed. Because we do have areas at Cedars which do not have RTLS coverage. Around the campus, they take it to another building. So it's very important for us to really know, yes, if it does meet the monetary value for tagging, where is this equipment actually going to be used on a day-to-day or operational basis. So that's very important. So once they do send out this request, our clinical engineering team does receive the request, and then we will evaluate whether we can tag this device or not tag this device. So our consultants did recommend the nursing division leads and unit champions. This was a program recommended by them. So the division leads are to work with the unit champions. Here we just have it broken down into 4 division leads: critical care, nursing, medical, surgical, and women and children's. So typically to provide more education, the division leads provide education to the unit champions who further relay this education to their respective floors as far as, does everyone on the floor know how to use RTLS? Does everyone on the floor utilize RTLS? Any other issues that they are having with the software? And then also, are they working with leadership to make sure that RTLS is implemented throughout their workflow? As far as even as Michele had mentioned, onboarding, it's very important that just from the get-go that all our new employees do know that we have an RTLS program. So loss prevention, probably the most important, has been a very key strong point of RTLS. As highlighted in this picture, we have the low frequency exciters, which are placed near soiled and linen rooms to combat the loss of equipment. So small equipment, as we mentioned before, such as teleboxes, Dopplers, range-finders. In the RTLS database, when we do add these units, we do incorporate a unique code. So when these equipments do encounter the sensors, when they do encounter these low frequency sensors, a phone notification is sent out to the charge nurse as well as the unit secretary. Here's a little screenshot of an alert, and these alerts do require immediate attention, and they will let the end user know, like, hey, your equipment has entered a soil room. Please go pick up the equipment and before it does get trashed. So the RTLS program here at Cedars has been rolled out. Currently, we're in 3 phases. So phase 1 saw the tagging of roughly 11,000 devices. It was split up into 2 parts. Part 1 started in January of 2022. However, it was delayed by 2 months due to supply chain shortages post-COVID. But we did pick up part 2 in March of 22. Phase 2 saw the tagging of about 2,400 tags, and it came shortly later in the year, going from September to October of 2022. And then currently, phase 3 is ongoing, which has started this past week. So just to start off with phase 1, we look to provide room level accuracy for the med-surg and ICU floors, as well as also area level accuracy for other main building spaces such as support services, imaging, ED, ORs, cath labs, GI, and other procedural spaces. As mentioned in the last slide, choke points along linen and trash paths were also part of the scope for this, for us to mitigate the loss of equipment. And this was our biggest phase as we tagged 11,000 assets from. Here's a list of assets that we did tag in phase 1. Phase 1 did pick up from the categories as mentioned earlier. We also did tag units that we did conduct a survey, and based off of the survey, we did incorporate more categories into phase 1. And then during the tagging of phase 1, we did get certain requests, which after taking into consideration, we also went about tagging. The units you see here underlined are units that have the smaller tags, which are only infrared based, as we do prioritize or favor the use of the larger tag. Because it does have a larger battery, it also relies on both infrared and Wi-Fi. Phase 2 was a continuation of phase 1 equipment. However, we did incorporate the addition of tagging of gurneys. We tagged roughly 400 gurneys. We also looked into tagging multiple parameter modules, also referred to MMSs, roughly 600, as well as a continuation of central issues equipment such as pumps and patient warmers. Phase 3, our most current phase, has had a few projects. Currently, we are working on bed tagging with the bed shop team, roughly 1,100 beds. Currently, we have about 800 beds tagged. However, once we reach 95%, we do want to do a handoff. By handoff, we mean once we do complete 95% of the tagging. The bed shop team is one of the few departments at Cedars-Sinai who have taken ownership over maintaining RTLS management in the long run. We've also worked on a PAR level coverage, and this has been most beneficial for the central issues team, as it was an expansion of PACU and NICU clean soil utility room areas. This allows their team to really, replenish and replace equipment in real time. And currently, we are focusing on surgical equipment for tagging on a need basis in the ORs, cath lab, and GI spaces. And we project roughly about 400 pieces to tag. So ongoing support, I'm going to talk about just some tasks that I take care of, being a unit matter expert at Cedars-Sinai for RTLS. I do provide our team with low battery reports for battery replacements. I review the RTLS inventory for improper date tagging, missing data, defective tags, which could be either physical or software defects, as well as creating icons and new groups for easier navigation. So just the overall maintenance and support. We do have other users that have analyst access to add or remove devices. So there are sometimes little hiccups which I'll need to really review on a consistent basis to make sure that this database is as accurate as it can be. And then, as mentioned earlier, we also do a review tagging requests submitted by end users. Here's a little table of the low battery report. This report is generated twice a week. So we did work with our consultants on the specific columns we would need, and the columns presented do provide our team members with as much information as possible to find these tags. The most important is the last column for us, which does display the percentage. Typically, they go based off of less than 30 days, less than 90 days, or completely depleted. However, consultants did tell us that this algorithm is very hard to predict. So we prioritize 30 days and 90 days just as evenly, and to really make sure that all our equipment is that we are not that we are not hitting any tags depleted. We do have this report generated twice a week, as mentioned, Mondays and Thursdays. So by the end of the week, we do want to have absolutely zero assets on the low battery report. So now, just shifting gears, I want to talk about the results we've had since implementing RTLS. Here we will talk about end user feedback, reducing time spent searching for equipment, loss prevention, workflow improvement, as well as inventory optimization. So throughout the phases of implementation, we have interviewed individuals from various departments to provide their feedback on how they've seen RTLS. It's been pretty positive. Here's just a few to point out. Our clinical engineering team has said that it's helped them find overdue equipment, equipment that was overdue for PMs, and it helps them stay compliant with the Joint Commission standards. Vet shop team representatives have also stated it's helped with daily checks in their clinical rounding. And then clinical transport services stated that they save them about 1 to 2 hours a week, which is a lot of time. Imaging representatives have also been very happy with the use. They said that it provides them visibility in their transfer monitors and gurneys. And they also pointed out, like, due to having a lot of equipment shifting within their department and also out of the department, when they do have this equipment, they can go or call the department, letting them know that equipment is gone. So it's really up their workflow as well. Surgical floors have also been very satisfied. It's helped them with time management. And just to point out the last ones, they're very surprised how easy it is to use. So it is a very easy system. It does not require rocket science. Critical care also seen. They've also had very positive feedback. They said it's improved their workflow productivity. Here's just just more feedback that we've gotten. This is probably the most recent, but just to take an average, it is very hard to get a quantitative number on how much time saving we are having, but just to take into measure objectively, the average based off of a survey conducted on around 60 individuals at Cedars-Sinai who use RTLS on a day-to-day basis. We did come to an average of about 20 minutes per day per user, which is substantial because that's more time given to patient care. And now I will turn it back over to Michele for the time savings.
Thank you. So we regularly monitor the number of accesses to our system. We saw ramp up and that it's stabilized at about 70 daily accesses on average. This is what we are seeing, and we hope to get beyond that to expand use. But already, if we assume that every access saves 20 minutes, that is 8,500 hours saved annually. That is not a lot. Clearly, it's a little over 4 FTEs, but and it's always it's difficult. You could associate a dollar value to that, but I'm not it's very meaningful because also it depends what hourly rate you would allocate, but we keep making sure that our staff is aware so that the system is used as much as possible. We do see that certain floors use it more than others. We're trying to understand if it is because they are, really changed their workflows, and others are still doing things the old way, or maybe certain floors are just more organized than others and don't need the system. In terms of loss prevention, we are monitoring what we are able to, prevent from being lost in terms of teleboxes and glucometers. We did reduce our wound vac rental losses by 80%. And there's a dollar value there. So we compare before RTLS and after RTLS. Now we're tagging every wound vac that enters the facility, so that when it's time to return it to the owner, we are able to find it. So that was a huge success. And also our UTLs, unable to locate or could not locate, decreased by 18% on our end for PMs. Improved workflows. Very important, again, difficult to associate a dollar value. Objectively, an improvement on parallel monitoring. Our central issues team is able to monitor real-time the devices that are located in a clean utility room to make sure that it's always, above the threshold that they set. But they also monitor all utility rooms so that they can optimize their pickup rounds. And do not waste time going to places where there is no need to go to. Adverse events, so in cases where equipment is involved in incidents, maybe not the serious, very serious incidents, but when patient care is impacted and maybe the device was not sequestered right away, now we are able to go back in time, see what device was in that specific patient room, and see where it is to in order to test it and make sure that it is validated. RTLS helped us a lot with our infusion pump remediation. We have certain infusion pumps that have gone through a series of remediations in the past few years. The last one, we had all our pumps already tagged, and it really changed the way, it really improved our workflow, because now we could enter in our RTLS system, we added a field where we could say check or remediate it, so that we could filter and focus and pinpoint the ones that were still left behind. So we had targeted, targeted interventions to retrieve the ones that are not remediated. But in general, for recalls, you understand that RTLS is also useful in order to reach the devices in a timely manner. I mentioned some unusual applications of RTLS. So when we reached out to pharmacy, they told us, I'm not really sure. Maybe the only thing that can help us is if we had some visibility into our medication exchange cards. Every morning, a team of 12 individuals, they take these cards on the floors to deliver the meds. So they were interested in doing a time and location study, understand the travel time, understand the variations day by day, individual by individual, and that really gave them some good insights to redesign maybe workflows, redistribute resources differently to make these rounds more efficient. And we also reached out to lab, and also, lab equipment is stationary, no need to tag them, but they said, maybe you can help us with our phlebotomists. So we tagged the phlebotomy cards because they were, they saw two kinds of benefits. One, when they receive staff requests, now they know real time where every phlebotomist is, and they can direct the closest one to, to do the blood draw. And the second type of benefit that they got is doing a retrospective review of where these cards had been, how much time was spent in each patient room, and comparing different floors, understanding that maybe there are, based on patient population, you spend more or less time to draw blood, and they are thinking of actually changing the way they dispatch staff. Because they only based on the number of orders, now they're taking into consideration, the fact that, certain patients just takes longer to perform the task. So very interesting. Inventory optimization is also mentioned as one of the possible returns of investment. So if you think that in your organization you have way more infusion pumps or another type of devices than you need, the system really gives you the hard data to show that you're right or you're wrong. In fact, we actually combined the data from RTLS with the data we got from our infusion pump platform, because our infusion pumps are networked and integrated, so we're able to see which ones are in use, which ones are not in use. So combining the two data sources, we see how many pumps in a certain floor are in use versus are not in use, and how long, for example, certain pumps stay in a certain location switched off. So we have a good deal of data that will allow us to go from a 30 to 35 utilization rate up to maybe even 50, reducing our inventory. In fact, we are about to replace our infusion pumps to refresh the fleet, and we are planning to buy less pumps, not to replace one for one, and we will be saving a good amount of dollars. So the dollars, where does it come from? If there is an inventory optimization opportunity, for sure that will be the big, bulk of it. It's very challenging to put a dollar value next to a time, search time savings. It's also related to the inventory optimization. There is also the benefit for our team that we need to do less PMs, less equipment, less PMs, so less labor, less parts, and that will, of course, free up resources for us. And then on the top part here, we wanted to, lay out what are the one-time expenses, but also the recurring expenses. So from our perspective, yes, we save time, searching for equipment or not having to search for equipment, but on the other hand, we are the team that takes care of battery replacement. So maybe it's like a wash out, the time that we save. It's for sure less frustrating for our staff, and that is really, it's priceless, improving morale and reducing frustration. But we feel that the time savings is more on the clinician side, that they can actually redirect their time to patient care. Looking ahead in the near future, what we're planning to do, we are planning to set up some rules for automated notifications for these assets that are sitting there, not moving, maybe forgotten, but also for assets that should not leave a certain force, but that are taken away. We are also thinking of adding the low frequency exciters at certain egress points to give us some more visibility into what is leaving the facility, shouldn't leave. Using Tableau, we've started connecting directly to the database to create dashboards for different purposes, presenting data in different ways. For example, if we are interested in seeing where our infusion devices are divided by inpatient spaces, outpatient spaces, what is being repaired in clinical engineering, what is waiting to be cleaned, what is ready to go. These are some maybe metrics that leadership would like to monitor. So Tableau allows us to do exactly that in case the RTLS platform does not have the capability to do that. And finally, again, we look forward to integrating the system with our CMS. That will make things so much easier. So we look forward to that. All right.